Hello, my name is Monok Shah, and today I'll be providing an introduction to active TB or tuberculosis diagnosis and treatment for primary care providers. My disclosures are seen on this slide. Overall, we'll begin with a review of local and global TB epidemiology, and then cover a review of the natural history of TB infection and disease, along with providing an overview of the various clinical manifestations of tuberculosis, and ending with a discussion of the approach to TB diagnosis and treatment. I'd like to begin by sharing the case of a 27-year-old US-born female who was HIV negative who presented to a local hospital in Maryland with 3 months of cough. Her chest x-ray indicated that she had a diffuse micronodular pattern consistent with an infectious process. She was initially treated for community-acquired pneumonia and ultimately discharged on a fluoroquinolone. However, given the prolonged cough as well as the somewhat atypical pattern on the chest X imaging, the team did consider alternative etiologies, including malignancy and Mycobacterium tuberculosis. Consequently, she did have sputum testing for smear microscopy, which was negative, and sputum testing for mycobacterial culture, which was pending at the time of discharge. She had no nucleic acid amplification testing, sometimes known as the GeneXpert assay. Approximately 1 month after the sputum was collected, the lab noted and alerted the health department that there was growth of Mycobacterium tuberculosis. The local health department consequently went to her home to identify and begin treatment, identify the patient and begin treatment for tuberculosis, but learned that she was already hospitalized in another hospital, again being treated for bacterial sepsis thought to be from a community-acquired pneumonia. The team was then alerted to the mycobacterial diagnosis and MTB therapy was started, but unfortunately, the patient did pass away. I'll come back to the relevance of this case in just a few moments as we discuss local TB epidemiology. In Maryland, it is worth remembering that tuberculosis was highly prevalent for the better part of the last 100 years. This was particularly true in Baltimore City, but also in Maryland as a whole. As you can see from this slide and historical documents, Baltimore and Maryland had one of the highest incidences of tuberculosis, particularly in the 50s, 60s, and even progressing through the 70s and early 80s. Part of why we begin our discussion here is not just for because of the historical relevance of tuberculosis in Maryland, but also because this leads to an epidemiologic phenomenon sometimes known as the cohort effect. Individuals who lived through the 50s, 60s, 70s, 80s, and even into the early 90s, lived during a time of higher TB incidence and transmission, and consequently, there is a higher prevalence of latent TB within this age strata or age cohort. Currently, the incidence of active TB has plateaued in recent years to approximately 3 per 100,000. It is worth noting that the majority of cases of tuberculosis in the United States and in Maryland are among non-US born individuals. Interestingly, we have observed an increasing proportion of cases that is made up of individuals with extrapulmonary manifestations of tuberculosis. HIV co-infection was a leading driver of tuberculosis disease and transmission in the early 90s, but the proportion of individuals with tuberculosis that are co-infected with HIV has declined over time. Nonetheless, globally speaking, HIV remains a significant factor in the risk for tuberculosis. Consequently, the highest incidence of tuberculosis is seen in individuals in sub-Saharan Africa, where the prevalence of HIV infection is also quite high. Overall, it is worth remembering the global context that tuberculosis remains the leading infectious disease cause of death globally. Because of the sheer populations, the largest number of cases of tuberculosis is found in India and in China and other parts of Asia. Overall, over 10 million people annually develop active tuberculosis, and a quarter of the world's population has tuberculosis infection. Nonetheless, even though we see a larger proportion of tuberculosis in non-US born individuals, providers should be aware that in Maryland there is ongoing transmission of tuberculosis locally, including in US born populations. Beginning in the early 2000s, a number of homeless shelters in Maryland experienced a tuberculosis outbreak. These were all genotypically linked, as was learned, because all isolates and diagnoses of tuberculosis undergo whole genome sequencing currently in Maryland. This single genotype, which was noted to be present in a number of cases among individuals developing tuberculosis experiencing homelessness, also emerged in the general population in Maryland beginning around 2015. Consequently, we have had genotypically linked cases, more than 30 of them in fact, in Baltimore as well as in surrounding counties in Maryland since 2015, and currently most of the cases that we are seeing are not connected to homelessness, and in many instances have been found in individuals that are younger with a median age of approximately 30 and affecting both men and women. A clinician's memo was therefore developed in 2018 by the Maryland Department of Health, and some of the key points to note are that individuals should be considered and evaluated for tuberculosis, in particular when individuals present with unresolving pneumonias or recurrent episodes of pneumonias without an alternative diagnosis. TB should also be considered in individuals with recurrent skin soft tissue infections, abscesses, lymphadenitis, or osteomyelitis without alternative explanations, or in those that are experiencing other signs or symptoms of TB, such as prolonged fevers, cough, or unintentional weight loss. Importantly, individuals should be considered for tuberculosis even without having clear traditional risk factors for TB. We have seen that many cases of TB have been associated with delayed diagnoses and consequently with extensive disease at the time of diagnosis, despite repeated encounters with the health systems. Additionally, because of the large amount of transmission that occurred as a result of the outbreaks amongst homeless shelters beginning in the early 2000s, it is recommended that individuals with a history of homelessness in Baltimore in particular, but in Maryland in general, should be screened for latent TB infection. Both skin tests or interferon gamma release assays can be used for the screening of LTBI or latent TB infection, but it should be noted that samples for microbiological testing with smear microscopy, culture, and GeneXpert, which we will cover in a few slides, should also be obtained if individuals are symptomatic or experiencing signs or symptoms of tuberculosis disease. While we have seen tuberculosis cases emerging in US-born populations, the majority of cases that are observed in Maryland continue to be in non-US born individuals, including local populations of refugees. Here I share the case of a 19-year-old from Nepal who reported weight loss, fevers, and a cough. She had clear epidemiologic risk factors for tuberculosis, as well as signs and symptoms that were consistent with tuberculosis, and so a chest x-ray was obtained, which also had suggestive imaging that pointed towards a diagnosis of active TB. All of these are factors that should be considered by clinicians when deciding when to evaluate for active TB disease. I'd like to just quickly review the natural history of TB infection and disease that might prompt you to consider tuberculosis in the differential diagnosis. Individuals at highest epidemiologic risk for initial infection include those that were born in, resided in, or traveled to places where TB is more endemic, or in individuals that have experienced homelessness or have lived in congregate facilities such as jails or prisons, or have had known close contact with TB. Most individuals with after initial infection will go on to have latent TB infection. However, after having latent TB infection, some individuals are at higher risk of progressing to active TB disease. These individuals should also be considered when for TB evaluation when presenting with classic signs and symptoms of tuberculosis. So stated differently, when an individual presents with signs and symptoms consistent with TB, such as fevers, coughs, night sweats, or weight loss, factors that should help prompt clinicians to think about TB in the differential include having host risk factors or epidemiologic risk factors for TB infection. Other elements that may point a clinician towards a diagnosis of TB is the presence of characteristic imaging findings such as cavities or pathological findings such as granulomas, which often occur when mycobacterial diseases are present. More broadly speaking, a good clinical pearl or rule of thumb is to consider Mycobacterium tuberculosis in your differential diagnosis whenever a person is not responding to first-line diagnosis and treatment for a variety of ailments. This is because TB can masquerade as many different entities. Here I share a case in which TB was masquerading as community-acquired pneumonia. The patient was 19 years old, born and raised in Maryland, was HIV negative, and had a fever, cough, and an infiltrate. She had a negative interferon gamma release assay performed and had a chest x-ray that showed a left lower lobe infiltrate, which looks for all the world like a community-acquired pneumonia. The patient was treated with ceftriaxone and azithromycin as per many clinical guidelines, but she had no improvement after 5 days. Consequently, additionally, her sputum cultures had were negative for bacterial pathogens. The team consequently considered this to be potential for antibiotic failure and switched her to moxifloxacin, and the patient started to improve. Given her unresponsiveness to initial therapy, the team did consider the potential for tuberculosis as an etiology and sent sputum for smear microscopy and mycobacterial culture. The smears were negative, but the cultures did eventually grow Mycobacterium tuberculosis. Whole genome sequencing was conducted and found that this was the same genotype as that found in the prior quote-unquote homeless cluster that I mentioned previously. This case highlights several important points. First, individuals with non-resolving pneumonias should be evaluated for atypical causes and bacterial etiologies, including Mycobacterium tuberculosis. The second is that a negative quantiferon should not be used as a triage test because it does not exclude or rule out active TB disease. It is important to remember that interferon gamma release assays only have a sensitivity of 60 to 90% in individuals with active TB. This case also illustrates the fact that conventional antibiotics can sometimes have activity against mycobacterial pathogens. Linezolid, moxifloxacin, and carbapenems are all drugs that do have TB activity and can lead to partial treatment. And in many cases, this can lead to delayed diagnoses because clinicians can be fooled with the antibiotic response. Mycobacterial culture is the reference standard, but there are new tests that can help diagnose TB faster, which we will cover in the next few slides. It is worth remembering that one should be alert for TB in otherwise healthy individuals in Baltimore as well as in Maryland as a whole. In recent years, we have found that and observed an increasing proportion of cases in which there is extrapulmonary manifestations of tuberculosis disease. On this slide, I show and share just a handful of sites where we have seen tuberculosis disease, ranging from testicular and general urinary forms of tuberculosis to Pott's disease, or otherwise known as TB osteomyelitis, to central nervous system abscesses and tuberculomas, jaw abscesses, as well as TB masquerading as pharyngitis. Which leads to the question, what tests should be ordered when one suspects active tuberculosis disease? An important consideration is to go after the site at which there is an abnormality. In many cases, this will involve the respiratory tract, and consequently, sputum is the biological sample that should be collected and evaluated. The tests that should be ordered include smear microscopy, mycobacterial culture, as well as nucleic acid amplification tests. I will reiterate that tuberculin skin tests and interferon gamma release assays are not sufficient to evaluate an individual suspected of having active TB, though they can be used adjunctively if all other diagnostic tests are unrevealing. Chest x-rays and other imaging can also sometimes be helpful to point clinicians towards a diagnosis of TB, though they are not confirmatory. When collecting samples from various sites of disease, it's important to remember to conduct microbiological testing before such samples or tissue samples are put into formalin or other forms of preservatives, which will compromise the viability of the organism and compromise the ability to recover the organism in mycobacterial culture. I'd like to just briefly review the test characteristics of the available diagnostic assays. A test that is commonly used by clinicians is sputum smear microscopy. Nonetheless, it's worth knowing that this test is the least sensitive of all of our current available assays in the diagnosis of active TB. The sensitivity is less than 40 to 60% in most situations and actually goes down in individuals with immunosuppression. The test is still utilized because smear positivity may correlate with infectiousness, but it is very important to recognize that having negativity by sputum smear microscopy does not rule out TB, despite the common language that is often utilized in hospital settings. The reference standard for diagnosis of TB is mycobacterial culture. There are both solid and liquid culture systems available, and the liquid culture systems are faster and more sensitive than the solid culture systems. Mycobacterial culture is required in order to facilitate phenotypic drug susceptibility testing, which can be performed after an isolate grows in culture. It is very important to make sure to send mycobacterial cultures from the site of disease. Stated differently, it is not particularly useful to evaluate for sputum alone when suspecting extrapulmonary forms of tuberculosis. It is also worth noting that the sensitivity of mycobacterial culture, despite being the reference standard, is not perfect. And this is particularly true for extrapulmonary forms of disease. In addition to mycobacterial culture and sputum smear microscopy, nucleic acid amplification tests have now emerged which have the potential to really revolutionize diagnosis of TB. Nucleic acid amplification tests, or NAT tests, rely on the detect tuberculosis by looking for MTB genetic material. It is currently recommended that at least one sample be sent for NAT testing in addition to smear microscopy and culture. These tests are very rapid, with results becoming available within 24 to 48 hours. There are a number of assays that are commercially available, but it should also be recognized that while these tests are much more sensitive than smear microscopy, they are not a replacement for mycobacterial culture. This is because these tests' limit of detection still is not as low as mycobacterial culture. Stated differently, these tests are not as sensitive as culture. Nonetheless, they are very important and should be utilized when available. The test that is available within the Maryland Department of Health is the Gene Expert assay, which is essentially a self-contained, fully automated system which allows for the detection of both Mycobacterium tuberculosis as well as the detection of drug resistance, and specifically rifampin drug resistance. It does so by looking for both MTB genetic material, but also looking for the specific mutations that confer rifampin resistance. The benefit of this test being a self-contained, fully automated system is that they have the potential to be used at lower levels of the health system, and this assay and instrument is increasingly being found and available in a variety of hospital settings, including throughout Maryland. The sensitivity of this NAT test is very high in smear-positive samples. It will also pick up 30 to 70% of cases in which the initial sample was negative by smear microscopy, but positive by culture later. These tests are, in many ways, a more sensitive version, these tests are very useful in being more sensitive than smear microscopy and by providing information on drug susceptibility. But an important caveat is that, similar to smear microscopy, a negative test does not rule out TB because its limit of detection is not as low as mycobacterial culture. So while specimens should be sent for smear, NAT, and culture, one must wait on culture results if the results of smear microscopy and Gene Expert testing are negative. Just stated again, the CDC recommendation is that at least one respiratory specimen should be sent for NAT testing in addition to smear microscopy and mycobacterial culture when suspecting pulmonary TB. I'd like to just move on by sharing a handful of cases in which the diagnosis of tuberculosis was missed. Here I show chest imaging from a 45-year-old from Nepal who presented to the intensive care unit with fevers, hypotension, and was HIV negative. The person had a T-spot test performed, which was negative, and had respiratory failure requiring intubation and initiation of broad-spectrum antibiotics. Because of the epidemiologic risk factors, and this pattern on chest imaging, which could be characterized as having a miliary pattern, TB testing was performed, and sputum was sent for smear, which was negative. Unfortunately, the clinicians misinterpreted these results and indicated that TB should be unlikely because the sputum smears were negative. As I've just indicated, smear microscopy is the least sensitive test that one can perform for the diagnosis of active TB, and negative results does not rule out tuberculosis disease. The team shifted gears to thinking about fungal pathogens and added antifungal agents, but continued to have worsening. Several days later, an infectious disease consultation was obtained, and sputum was additionally sent for nucleic acid amplification testing with the Gene Expert or GXP assay, and was positive for M. tuberculosis. The person then was able to be started on TB therapy, but unfortunately passed away 14 days later. A clinical pearl here is that when a person presents with TB sepsis, there is very high mortality, similar to bacterial sepsis, if appropriate therapy is not started early. In this case, nucleic acid amplification testing could have and should have been performed according to current clinical practice guidelines and may have allowed for earlier recognition and diagnosis of tuberculosis and more prompt initiation of therapy. It is important to also recognize and remember that a negative IGRA or tuberculin skin test does not exclude a diagnosis of active TB disease. I'd like to additionally share another case in which tuberculosis diagnosis was missed and delayed. Here I show a chest imaging from a 35-year-old US-born HIV-negative female who presented with 6 months of intermittent fever and weight loss. She was treated for community-acquired pneumonia 3 separate times. She was eventually referred to a pulmonologist who performed a bronchoalveolar lavage, or BAL, and was given treatment for a bacterial lung abscess with cultures pending. Given the recurrences, she came to the local health department for a second opinion. At that time, sputum was sent for nucleic acid amplification testing, and a diagnosis of tuberculosis was made within a few hours. The BAL results did eventually come back positive for Mycobacterium tuberculosis several weeks later. But I share this case to once again reiterate the importance of nucleic acid amplification testing, including in individuals in whom there is initial sputum smear negativity, because it can allow for more rapid diagnosis of active TB disease. Secondly, this case once again highlights that individuals, even those that are US-born, that present with non-resolving pneumonias should be evaluated for active TB. Within the state of Maryland, I would like to point out that all cases of active TB must be referred to the local health department in which a person resides. When defining active TB, I would like to note that the local health department should be alerted both in cases that are confirmed microbiologically, as well as in situations in which a clinical diagnosis of TB is made and treatment is being initiated. Within local health departments, tuberculosis therapy and case management are available, along with directly observed therapy, which is the standard of care for all patients, both those that are microbiologically confirmed, as well as those instances in which TB therapy is initiated empirically. Health departments also have limited capacity for additional testings and monitoring, including chemistries, chest imaging, and physical exams, and therapeutic drug level monitoring. But in many cases, The local health department must work in close conjunction with primary care physicians to manage individuals with active TB disease. Health departments are also tasked with completing contact investigations whenever there is a case of tuberculosis. And it is therefore extremely important to maintain strong communication with your local health department whenever you suspect or initiate therapy for active TB. When treatment for TB is initiated, the standard current regimen is that of 6 months of therapy utilizing an intensive phase of 4 drugs consisting of rifampin, isoniazid, pyrazinamide, and ethambutol, and a continuation phase of rifampin and isoniazid, which continues for 4 months. Directly observed therapy is the standard of care in the state of Maryland. Here I just summarize the current treatment regimens that are recommended by the CDC, ATS, and IDSA in the form of a table. All therapy for tuberculosis should be undertaken in conjunction with your local health department and the Maryland Department of Health. While most cases of tuberculosis in Maryland involve isolates that exhibit drug susceptibility, drug resistance remains a concern as well. Here I share the case of a 28-year-old who was born in India and presented to her local hospital at 27 weeks of pregnancy for preterm labor. She was afebrile, had no localizing complaints, but was noted to have poor weight gain. She continued to she began to develop persistent tachycardia, and a CT scan was ordered to evaluate for a pulmonary embolism. It was at this time that chest imaging was suggestive of a pneumonitis, and given her epidemiologic risk factors, tuberculosis was on the differential. Sputum was collected and was positive by sputum smear microscopy, but additionally, a gene expert test was performed, which confirmed a diagnosis of Mycobacterium tuberculosis, but also provided rapid identification of rifampin resistance. Culture results became available several weeks later with phenotypic drug susceptibility testing indicating both isoniazid and rifampin resistance. This case scenario, therefore, represents an instance of multi-drug resistant tuberculosis. All cases of MDR-TB require a Maryland Department of Health and local health department referral for further consultation. While we cannot review the full management strategies involved in treatment of drug-resistant TB, I did want to just highlight that guidelines have recently evolved and changed. This is because of the advent of a number of new drugs that have recently become available. Consequently, whereas historic regimens for multi-drug resistant tuberculosis included intravenous or intramuscular agents such as amikacin and streptomycin, those agents are now considered considered essentially second line. Most conventional multi-drug resistant TB regimens currently involve an all-oral regimen, though the timeline is still substantially longer than that available for drug-susceptible TB. Overall, I just want to highlight that health departments have primary responsibility for TB prevention and control, but that the management of individuals with TB infection and disease requires close collaboration between the public and private sector. The local health department is available to help primary care clinicians conduct contact investigations as well as to advise and help perform clinical and diagnostic evaluation for tuberculosis. In summary, tuberculosis is not gone from the state of Maryland. One should consider TB both in non-US born individuals, but also in US born individuals who have experienced homelessness, or in those experiencing or presenting with unresolving pneumonias or other subacute or chronic signs or symptoms of TB, including extrapulmonary TB. When evaluating for active TB, it is important to send specimens for smear microscopy, culture, and nucleic acid amplification testing. While culture remains the reference standard, it is slow. Nucleic acid amplification testing is not as sensitive as culture, but can help provide a more rapid result. IGRA tests and skin tests are not triage tests, and negative test results do not exclude active TB disease. When treating for active TB disease, it is important to consult with the local health department in Maryland Department of Health. 6 months of therapy with rifampin, isoniazid, pyrazinamide, and ethambutol remains the standard of care for drug-sensitive TB, but newer all-oral regimens are becoming available and increasingly utilized for drug-resistant TB cases. Finally, it is important to remember that quinolones, carbapenems, aminoglycosides, and linezolid all have MTB activity and can sometimes lead to partial treatment and can sometimes obscure the diagnostic process. I'd like to end just by sharing a set of resources and contact information when evaluating individuals for active TB, or if you have questions related to TB, please make note of the significant resources that are available in the state of Maryland, both at the Maryland Department of Health as well as through your local health department.